everyone. It's a pleasure to be back again, giving a talk later in your course this time. You will have heard from myself earlier in your training, but I'm back again today with some other colleagues from NEDPRO talking about education, empowerment, entrepreneurship in the community and its importance and the role it plays in diet and nutrition. So this talk will be broken down into 3 sections, 10 minutes each. So my section at the start, so my name again is Dr. Luke Buckner. I'm a junior doctor in the NHS with training in nutrition. And why I'm talking today, I guess, is from the experience I've had working in India in our mobile teaching kitchen. And I'm joined by colleagues who also have worked in that intervention, Kai Kargbo and Sanchita Banerjee, who will introduce themselves now, and they'll be talking about these other topics for 10 minutes each. So I'll let them introduce themselves and then we'll get started. So over to you, Kai.
Thank you, Luke. So hello, everyone. My name is Kai Kargbo, and I am a research assistant and communications officer at NEDPRO. I am also the co-lead for the US and Pan-African Regional Network, and I have a background in public health.
And over to you, Sanchita.
Hello, participants. I am Sanchita Banerjee, Project Officer of Mobile Teaching Kitchen Project. I am also the Deputy Lead of NEDPRO Regional Network for the India and South Asia region. So today I will actually go for some insights of the MTK project right from the Calcutta. Thank you.
Okay, so now we'll get started onto the first section of the talk with myself on the question, is diet solely about knowledge and choices? So to answer that question, I thought the best way to pose this to you is to start by what we know we should be eating to be healthy. And from a previous lecture we gave with Shane McAuliffe from the United Kingdom, a dietitian there, we went through the Indian guidelines and some of the key points from the Indian government website, which also summarizes some of the dietary advice people should be following, are very common across the globe, really. They're similar dietary guidelines. Consuming 5 portions of fruit and veg per day, choosing unsaturated fats over saturated fats, whole grains over refined carbohydrates, so that's brown rice over white, for instance, having less than 1 teaspoon of salt per day. And these are, as I said, very common across the globe, and generally, apart from perhaps defining the amount of different things, these are similar recommendations that we would see in the US and the UK, and the same in India as well. So most of those probably won't surprise you. I guess you've had the benefit of a previous lecture, but even before then, most people would know they probably should consume fruit and vegetables up to sort of 5 portions a day. And some may even know that after that point, there's still additive benefits of consuming up to 7 or even 10 portions of fruit and veg per day. And as Shane was telling us in his talk, variety is really key in what you're consuming. But the question is, how many people in India really follow these guidelines? And this is probably the same when we look in the UK and in other populations too. The average intake for fruit and vegetables in India is actually only 3.5 servings per day. So it's 1.5 less than the recommended amount. And it's important to know from the evidence that 5 is kind of a number that, as I said, it doesn't show the best intake that we could possibly get from eating fruit and vegetables. It just shows a target where the government or the guideline makers hoped that people would at least get to. So 3.5 is concerning in that it's quite low. And this is actually even lower in generations that were sort of younger, so younger people and students as well. And that starts to trigger a few thoughts into why are people that perhaps students, for example, have access to education. They sometimes are from families where they're able to actually attend schools or universities and therefore are in better places in the world and have less deprivation. And so even in those groups, if there's low intakes, it must be worse in those that struggle from these factors. So this diagram here shows the consumption of fruit and vegetables in India, and it's just to highlight again in a visual way what I was just telling you. So 5 portions of fruit and vegetables is equivalent to about 400 grams approximately. So if you look here at this graph on the y-axis, which is the bottom line across there, so going from 0 up to 1000, you can see the consumption amount of fruit and vegetables. So the box in green highlights a level above the recommended amount, so 5 portions or more. And then you see on the left-hand side, so the gray lines going up, that is how much of the population are at that level. So the vast majority of the Indian population are well below 400 and are actually sitting, the peak of which is about 150 to 200 grams, so half really what we would be expecting. And obviously there is a slight slope to this, and so the area under the curve is going to be slightly higher than that, but it shows a really concerning picture and one that needs to change for the optimization of Indian population's diet. So then it comes back to the question, why are so few consuming enough? I guess when we're looking at this from a perspective of doctors and dietitians, and even those on social media who have many opinions about what people should be eating, they often think that it's a choice of lack of education, people don't know what's good for them, or that they just choose not to eat it, and therefore perhaps they shouldn't even have access to healthcare, as some of the things that people talk about on social media, not doctors and dietitians, I hope. But actually what we see is that consumption is often to do with income. There's certain castes in India that have better nutrition of fruit and vegetable as a case example, and certain geographical locations, so cities versus rural settings. All of these factors affect how much fruit and vegetable is consumed by their population. Yet across the report, so the phytonutrient report in 2016 in India, 95% of people knew fruit and vegetables were beneficial. So it's not just the knowledge that needs to be improved, but really the ways that we can help people put it into practice. And this really feeds back into what the WHO, so the World Health Organization, have classed the social determinants of health, which includes your income, your education, whether you work in poor conditions, whether you live in poor conditions, and whether you're discriminated or isolated from society. And all of these factors together feed into things like your diet, your availability of places to exercise well, your time to exercise, your time to consume healthy diets and prepare them, and also factors like your access to good quality healthcare, which ultimately has greater significance than the healthcare or lifestyle choices themselves. So about 35 to 50% of health outcomes can be captured in the social determinants of health. So the question then comes back to how can we help people to make a change? And obviously what I'm saying is not that we shouldn't educate people. It's still very important that we emphasize the benefits of things such as fruit and vegetables and other dietary changes, but that's not acceptable on its own. We have to have support for those people to then make changes to their lifestyle, which is never easy. And so this could be through directing them to local support groups. So if you're working with a community where they don't have much income and they're struggling to access fresh fruit and vegetables because of money, then there may be food banks that are available where people have donated excess food for them to eat a healthy way. There may also be cooking groups and things where you're showing people how to cook, because culinary expertise, so your ability to cook, can actually significantly impact the food you eat. Also recognizing that there may be certain situations where you're in a more privileged position as the person giving advice than those that you're giving advice to, and they may need to actually have lower cost alternatives to what you're recommending. So there's no real benefit in recommending a very tasty, expensive fruit which they can't afford. It'd be much better going for a simple solution and recognizing that that would still be a real good addition to their diet. And if they can incorporate that to their family, they'll make a significant improvement. Lastly, we have to always be ready and willing to address inequality and discrimination and call that out when we see it. And that's across individual levels, community levels, and also at policy level too. So advocating for change in government policy is key in this aspect. So for me, it's time to make a change, and COVID's really highlighted that. It's the incidence and mortality. So the amount of cases and the deaths from COVID-19 were double in the most deprived areas of the world compared to the least deprived, which is very sad to see, but also reflects what we see for a number of other chronic illnesses across years and decades. Also, people living in high-income countries have, on average, 19 years more life than those in low-income countries. And so, again, that's a really significant factor and something that we should, in my opinion, be fighting to change globally, but also to recognize that within countries as well, there's massive differences in life expectancy from those deprived areas versus those with high income and affluent areas. So for me, it's time to empower communities, advocate for them, and support them so that those who are less privileged can actually take back control of their health and make those choices that we educate them about. So thank you for listening to my section of the talk. I hope that stimulated some thoughts and allows you to think about the wider aspects of diet. And now we'll hear about ways that we can start making change through our next speaker, Kai Carbo.
Thank you, Luke. Thank you very much, Luke. So let's recall the social determinants of health. These are factors that influence our health as individuals and as communities. Now, unfortunately, these health resources are not evenly distributed across a population. And what this means is that certain groups of people do have worse health because they do not have access to healthcare services, transportation, education, or healthy foods. Health inequity is an unfair system and it is preventable, and therefore we need to address it. So how can we improve health outcomes and address health inequities? By public health interventions. And these interventions can target one of four key areas. It could be our health behavior, physical environment, or the social and economic environment. So how do the social determinants of health, diet, and food choice, how are they related? There's several factors that affect our food choices. Some of these factors are biological and social, whereas others are economic and physical, such as education, nutrition education, the cost of fresh foods and healthy foods, access to the healthy foods, and the skills required to prepare healthy, nourishing meals. So in this presentation, we're going to be using the Mobile Teaching Kitchen as a case study for a nutrition and health intervention. And what we try to do is to address poor diet quality and related health outcomes by improving dietary diversity and nutritional awareness through education and hygiene workshops. The MTK was launched in 2018, and we targeted mothers and children in 2 slums in Kolkata. This intervention was implemented in 3 stages, starting with a needs assessment, and then the See One, Do One, Teach One workshops, and finally the micro-enterprise stage, which is an ongoing process. The MTK took about 7 months to implement. So during the first stage of this intervention, our volunteers obtained consent from our participants and collected some demographic information, which included age, employment, and the level of education. We also tried to identify gaps in the community with regard to nutrition-related knowledge, attitudes, and practices. And lastly, we determined the current health status of our participants prior to starting the intervention and the level of malnutrition among that group. And for this, several indicators were used, one of which was the BMI, but we also screened for micronutrient deficiencies. So during the workshops, we followed a See One, Do One, Teach One method, which is a practical storytelling method of transferring knowledge. Now, the See One, Do One, Teach One workshops are comprehensive nutrition education, cooking, and hygiene workshops. We followed a template menu that uses ingredients that were found in the local community. Now, at the end of the cooking demonstrations and the workshops, we assessed our participants based on their retention of the knowledge material, but also their ability to teach others. Successful candidates, which we refer to as our MTK champions, are then encouraged to form a micro enterprise, during which they can generate some income for themselves and their families, but also transfer what they've learned, all the knowledge that they've learned, to members of their community. So this is just a brief overview of the MTK intervention, starting from the needs assessment all the way down to knowledge dissemination to the community. So a key part of designing and implementing a successful intervention is the evaluation process. This is the process that tells us whether or not our intervention was successful. Did our outcomes match our expectations? If not, why? What did we learn, and what other areas are there for future research? So the MTK was evaluated using knowledge, attitudes, and practice questionnaires, but also we tried to measure changes in body weight and mid-upper circumference. So what we saw were improvements in nutrition knowledge after the intervention, but also slight improvements in micronutrient deficiencies among participants after 6 months of the intervention. Now, we must interpret these findings with care because we worked with such a small group of people, and therefore we need more research to determine the effectiveness of teaching kitchens as a tool for education. Now, beyond our direct participants, we wanted to also empower the community to make healthier choices regarding their diet, which will then lead to better health outcomes for members in that community. And what we saw to date was that in Kolkata, with 5 mobile teaching kitchens and 20 direct participants, we create over 2,000 opportunities for health promotion within a community. Thank you all very much for your time, and I will now like to call on Sanjita, our colleague in India, who will then talk to you about some of the lessons we learned whilst implementing the MTK.
Many thanks, Guy. You have described the technical process of mobile teaching kitchen so nicely. And participants, this is Sanchita. Now I'm going to share some soft elements of the intervention as the insights. As you know, any successful implementation of any intervention needs a matured and strong team, where the team members should have some specific qualities, like they should be accepted by the target community, they should be gender sensitive, unbiased, analytic, committed for their work, optimistic, patient, and most importantly, caring for and listening to the target community about their views and concerns. Here in the picture, you can see the implementation team of mobile teaching kitchen. As Kai already mentioned, that to the see one, do one, teach one is the vital phase of this intervention, and where the actual transformation takes place in the lives of participating mothers. Here, the participating mothers get exposure to diversity of foods, open to observe, touch, relate, and taste. Here, they gathered many unknown information about their known food and ingredients, which is very vital for their health and well-being. In this session, these participating mothers are engaged with different types of activities. And since this is a very much participatory learning process, all the mothers are actively engaged with different activities and they are open to share their experience also. This is a joyful learning process and they enjoy the learning with their peers. And ultimately, a spontaneous inclusion is happened, which is really visible throughout this process. The implementation of this mobile teaching kitchen sessions also need to ensure the team building and fellow feeling among the mothers. They should feel secure, confident, and the process should keep going without any pause, and a continuous upskilling is needed among the mothers. Here in the picture, you can see the trained mothers who are now the champions of this intervention. They are on the stage and it is very much visible that they are confident. They can now raise their voice and open to address the audience and impart the nutrition education. During the journey of empowerment, one needs to be flexible, creative, and open, because there is no orderly linear progression in this intervention, because there is no structured and step-by-step process that you can follow. You should expect unexpected and always be open for continual learning and adaptation in these interventions. And you also have to be open for taking steps backward sometimes in order to go forward. The Mobile Teaching Kitchen initiative was initiated basically to train the potential mothers from slums and to spread the information on nutrition to their peers. But in reality, after the intervention and during the course of intervention, we realized that this has been created nutrition educators and the trained champions from grassroots level who are now educating families, neighbors, common people, customers, and most importantly, their previous employers, where they were used to work earlier. Here in the picture, you can see in the left side, the slum from where these mothers were coming, and they used to work in the multi-story buildings as a daily labor, and now they are visiting these employees to educate on nutrition. So it is revealed that nutrition education is an universal need. Bhavishya Shakti being the name of this intervention, and it means empowering the future. Here, this intervention is just not an intervention, but it is an ongoing cycle of education, learning, and empowerment where gender, equity, and equality are addressed, not in a planned way, but as an inbuilt mechanism. And we think this is the uniqueness of this intervention. Finally, we are moving towards the empowered future. And thank you so much for listening. And all are welcome to Kolkata to visit. This process of empowerment and education is happening. Thank you.